Hope you all have enjoyed your break. If people could return to their seats, please. And perhaps somebody could tell our colleagues outside that it's time to come back. I'm Susan Gennaro. I'm the Dean of the William F. Cannell School of Nursing, and it's a real pleasure to be here today. I think, as Alberto Gadenzi so well said, being a dean of a school where the science has to do with many of the issues that we're talking about today, it's particularly wonderful to be here, and we're very thankful for all the hard work that all the faculty and staff did in putting today together. You know, the scientists in the School of Nursing spend a lot of time thinking about disease prevention, health promotion, and health disparities, so it's particularly important for us to be participating today. And as a NIH researcher who's been very involved in health disparities in pregnant women, it's particularly wonderful to look at the presentations and the posters here. But I have to say, one of my greatest pleasures today is being the moderator of the session on policy, because I think, as our keynote speaker so well pointed out, policy makes such a difference in terms of population health. So I have the great pleasure of introducing to you speakers on 3 different topics. First, I'd like to introduce Dean Hashimoto and Erica Sabbath, who are going to speak on the impact of workplace policies on hospital workers. Dean Hashimoto is an associate professor in the law school who teaches healthcare law and has published on the intersection of science, medicine, and law. And Erica is a researcher and an epidemiologist, assistant professor in the School of Social Work, whose work is on workplace exposure to health disparities. Our first group, our second presentation, is from Summer Hawkins on tobacco control and maternal child health. I've had the pleasure, actually, of publishing with Summer on some work that we were doing in the Bronx with secondhand smoke and how that makes a difference to maternal infant health. And Summer is also an epidemiologist whose work is on improving the health of mothers and children. And then lastly, our last panelist is James Keenan, who is the Peter Canisius Chair, Director of the Jesuit Institute, and Director of the Gabelli Presidential Scholars Program, who's going to be speaking about policy and HIV and BC students. So please join me in welcoming such an illustrious panel and our 2 first speakers.
Eric and I are thrilled to be here today on this day that honors Dr. Landrigan and the very rich research by students and faculty alike on this important topic of public health. Eric and I are conducting research on issues that involve the impact of hospital organization and policy on the safety and health and well-being of hospital workers. I'm going to talk briefly about my journey from law and medicine, in which I was trained, to this particular area of research. I'm going to be talking also about a research database that Erica and I have been involved in terms of constructing, and the types of research that have come forward from that database. I'm trained in law, medicine, and public health. In fact, I share the same medical specialty that Dr. Landrigan is in, this area of occupational and environmental medicine. It's a very little known area of medicine, and it's considered to be in the area of preventive medicine, in the area of public health. Indeed, a public health degree is required as part of one's medical training. The reason I came to it is that I trained in law and medicine before trying to figure out sort of what am I going to do with this career. And what I found in the area of public health is that it intertwines in a very deep way, concerns about social justice on the policy side, as well as having very strong clinical implications. I began my medical training at the Mass General Hospital, where indeed the founders of this particular medical specialty began, Alice Hamilton and Harriet Hardy, who did a number of research studies in the area of asbestos and beryllium exposures. Public health, and what I think is great about public health research is that it's a very practical approach to life. Basically, in order to be a good public health researcher, you have to identify the critical issues. And if you come up with important findings, they very quickly translate in terms of applying to what is going on in the community. And that really, I think, is sort of an important drive to this area of research. The particular kind of research that Erica and I are going to be talking about today is in furtherance of this concept called total worker health. Total worker health. And this approach encourages employers, workplaces, to integrate together concerns involving not just the safety of workers, but also trying to integrate that in with the health and wellness of workers. So the idea is for occupational health departments to combine their interest in protecting the safety of workers with programs that promote the health of workers, programs that promote the wellness of workers. There are only 4 research centers that are supported to do this work on total worker health, and they're supported by large grants from the National Institute of Occupational Safety and Health. The one that Eric and I are collaborating with is over at the Harvard School of Public Health, and the principal investigator there is Glorian Sorensen. In our particular study, we focus upon a group of nurses and nurses' aides at the Mass General Hospital and the Brigham and Women's Hospital. Healthcare workers, the health of healthcare workers is a very prominent part of public life. Certainly the Ebola crisis is a good example of where there are great concerns about the impact on healthcare workers. But if you look back and think back in terms of the number of other public health issues involving health workers, they are in large number. They include things like the swine flu epidemic. And what we're going to be talking about today is yet another kind of epidemic, non-infectious in nature, and that is the epidemic of injuries among healthcare workers. What we have put together in the course of this project in connection to this Harvard Center with Excellence is what we call an integrated research database. And what this combines together is an unusually large array of sources of data, beginning with occupational health data in terms of clinical visits by hospital employees, but also incorporating other kinds of data, such as government compliance data associated with OSHA reporting of injuries, or the reporting to the Department of Public Health regarding sharps and blood exposures. But it also incorporates other information as well, human resource information, the salaries of workers, the absence of workers from the workplace, as well as quality of care information in terms of, what is the quality of care that is delivered by various patient units. Our hope in assembling this database is that we will develop a 360-degree view of the health of hospital employees. There have been a number of publications that have already flowed from this particular database, many of them in connection with a survey which is also tied to the database. We've surveyed basically 1,500 healthcare workers, nurses and nurses' aides at these 2 hospitals about a number of subjects. And as a result, the kinds of topics that have been published upon include not only injuries, but also musculoskeletal pain at work, sharp exposures, the impact of shift work, sleep deficiencies, the physical activity of workers. The kinds of studies the kinds of publications that have resulted have included information like, how active are nurses? Because nurses have complained about, well, gee, I can't really participate in a wellness program. I'm already so busy and tired from work. And one of the things that we have found from our studies, for example, is that surely they are fatigued and surely they are busy, but unfortunately, the kind of work that nurses do does not result in the kind of exercise activity that is good for your cardiopulmonary system. And so it's that kind of work which integrates clinical data, insurance data, other kinds of reporting data, which leads to very interesting results. Lastly, what I want to say is this, is that Erica, who has just joined Boston College during this year, sort of represents a really important resource for this kind of work. Indeed, she's going to be leading the research team on this database project. She comes at it from the point of view of social epidemiology, and she's a professor of social work. And so I think this particular research endeavor shows the importance of multidisciplinary research. And along with this database that integrates a variety of kinds of data information, we hope to continue to put forth a number of very important studies. So I'm going to turn this over to Erica, who will describe one of her studies involving this research database.
Thank you so much, Dean. So as Dean said, I'm going to be talking about a study that we did that sort of exemplifies the promise of this database and what we want to do with it in the future and how it can impact public health policy. So injury at work is quite common in the US, quite costly. And while we think of industries like mining or construction or manufacturing as ones where people are especially injury prone, in fact, healthcare workers have higher injury rates than any of these other occupations. And the other issue in nurses that I'm particularly interested in is abuse and harassment. It's quite common. In a given year, about 40% of healthcare workers report being verbally harassed or abused. And for nurses in particular, they're kind of at the nexus of a whole bunch of different organizational and interpersonal dynamics in the hospital that contribute to them not only being receiving potential abuse or harassment from patients or patients' families, but also from supervisors, from coworkers, from physicians, and it's a very fast-paced environment. Emotions can be running very high. And the question is, we're interested in these two things, but how are they connected? What's sort of the physiological mechanism that might lead abuse to injury? And I want you to think about being at work and someone starts screaming at you and what happens to your body. So sort of from the head down, it's very upsetting. You can become very angry and distracted and, for example, stick yourself with a needle. When you imagine someone screaming at you, you tense up. And when you're doing very physical tasks like a nurse has to do, like lifting a patient or moving equipment, that can increase strain on the muscles. And when the fight or flight response is activated during one of these episodes of abuse or harassment, pain perception can be dulled. So usually you would lift a patient, your body tells you this patient is too heavy. In this situation, that trigger is off. And so when this happens over and over again, people can potentially develop muscle and skeletal injuries. And what we wanted to do was test this using the database. We have this occupational injury database. As workers are injured, they report their injuries to occupational health services on an ongoing basis. As Dean said, we also did this survey of patient care workers. And you might just ask, you're asking people about whether they were abused. Why don't you just ask them whether they got injured? And the power of this database is that by separating out the way that we collect data on the abuse and on the injury outcome, we prevent some of the biases that can arise in epidemiologic research. So what we found is that indeed abuse and unfair treatment were quite common in these healthcare workers. Between a third and 2/3 of people reported exposure to the different elements. And what we found is that people who were yelled or screamed at had a 52% greater risk of injury compared to people who were not. People who received hostile or offensive gestures had a 43% greater risk of injury compared with those who didn't. And those who were sworn at had a 41% greater risk of injury. And what we also found is that the more of these exposures someone experienced, the greater their risk of injury, what we call a dose-response relationship. And this is a policy session, so you might be saying this is all very interesting, but why does this matter for policy? And it's because with the power of a database like this, we can answer questions that have real implications for hospital policies and practices. So for example, I just had a study funded that aimed to look at these incidences of work stress, abuse, unfair treatment, and whether there are economic costs to the hospital associated with those kinds of exposures, things like healthcare utilization or long time out after an injury. Dean and I are now writing a grant sort of for the next phase of this project to see whether these patient care worker experiences are connected with the health of their patients, whether a workforce that has a lot of physical or psychosocial exposures have poor outcomes among their patients. And when we do these kind of total worker health interventions, we can not only see, okay, did this intervention decrease levels of abuse and harassment in workers, and was their health improved as a result, but from a hospital level, we can say, did people return faster after an injury? Were they injured less often? Did they leave the organization less? And so it allows us to answer these really complex questions that we might not be able to answer if we just had these self-report data in front of us. So that's sort of one application of this database. We have many more planned, and we're really excited to see the kinds of questions that we'll be able to answer in the future about workplace exposures and the way that they connect to some of these bigger outcomes. Thank you.
Great. Hi, thank you. I really appreciate the opportunity to tell you about my work. So my name is Summer Hawkins. I'm an assistant professor at the School of Social Work. So I'm actually first going to show you some of our data. So from the Centers for Disease Control and Prevention, I've obtained information on every birth from 29 states from 2000 to 2010. So what you're looking at here is actually approximately 18 million babies. Now, the birth certificate asks mothers whether they smoked during pregnancy. And so this is showing the decrease in the prevalence of maternal smoking during pregnancy over time. So in 2000, the prevalence was about 11.9%. In 2010, the prevalence was 8.9%. And so we need to ask, whether this is a public health success. So really, the short answer is yes, and my talk should really be ending here. But I'm a social epidemiologist, and I'm interested in not just looking at the average, but in fact, I'm interested in identifying those groups that may be at higher or lower risk. So first, we know that race ethnicity is an important determinant of health. And in fact, what you can see here is that maternal smoking during pregnancy varies widely by mother's racial ethnic group. And so you can see that white mothers are at the highest risk of smoking. And in 2010, the prevalence of smoking was about 12%, followed by black mothers, the prevalence was about 8%. And then there's very low levels of smoking among Asian and Pacific Islander mothers and Hispanics. We also know that education is one of the most important predictors of health and health behaviors. And again, what we can see here are very strong gradients in maternal smoking during pregnancy by mothers' educational attainment. So what you see here is that mothers with less than a high school degree, so degree 0 to 11 years of education, are at the highest risk of smoking, followed by mothers with a high school degree, followed by mothers with 13 to 15 years of education, and mothers at lowest risk of smoking are college educated. But to tell the whole story, we really need to look at both maternal race ethnicity and education together to help identify the groups at highest risk. So when you do that here, you see that among white mothers with less than a high school degree in 2010, they were smoking at rates of about 35%. So that's 1 in 3 mothers were smoking during pregnancy. Mothers with a high school degree were smoking at about 20%. Mothers with 13 to 15 years of education or some college were smoking at 10%. And then college-educated women were smoking at about 2%. Now we look at black mothers, we still see, again, very strong gradients by education, but everything is much more compressed. However, the groups still at highest risk for smoking during pregnancy were those women with a high school degree or less. So you might be thinking, how many women does this actually refer to? Well, approximately 1/4 of white women have a high school degree or less, compared to about 40% of black women have a high school degree or less. So now I want you to consider the size of the population that this is affecting, both the mothers then and their babies. So the effects of smoking on adult health are very well established. We know that smoking in adults increases the risk for a range of cancers, including lung disease, as well as cardiovascular disease and other outcomes. But in utero exposure to tobacco smoke is one of the most modifiable determinants of low birth weight and preterm birth. Now, we don't want our babies born too light, and we don't want them born too early. So half of all mothers who quit smoking during pregnancy actually resume postpartum, which increases their baby's risk for sudden infant death syndrome, or SIDS, as well as children's risk for respiratory infections, asthma, ear infections, and other conditions. Now, current guidelines from the American College of Obstetrics and Gynecologists recommend taking an individual perspective for treatment, so specifically offering tobacco dependence interventions at the first prenatal care visit as well as throughout pregnancy. Now, while this approach would actually be fine, there are known disparities in when women start using prenatal care. So if you look by maternal education, over 90% of mothers with a college degree start their prenatal care during the first trimester, compared to 66% of women with less than a high school degree. And so I wanted to really test the potential impact of a population-level intervention. So there's been a global expansion of tobacco control policies, particularly over the past decade. There have been increases in cigarette excise taxes and the enactment of smoke-free legislation. Now, tobacco control programs, they often take a very multi-pronged approach. So we know from research that cigarette taxes reduce the uptake of smoking, and they encourage smokers either quit or reduce their consumption, meaning the number of cigarettes that they smoke. We also know that smoke-free legislation that has come about to protect non-smokers from secondhand smoke exposure has been very effective. But despite these achievements, pregnant women have received very little attention. And so I've been collaborating with Professor Kit Baum, an economist here at BC, and we've been conducting a series of projects looking at tobacco control policies. And so the question that I'm going to be addressing today is, do tobacco control policies improve the health of mothers and their babies? And to do that, we conducted 2 studies. The first was to evaluate the impact of state tobacco control policies on disparities in maternal smoking during pregnancy. And the second was to examine the impact of these policies on birth outcomes, such as low birth weight, such as preterm birth, according to maternal race, ethnicity, and education. Now, the methods, we're going to use the same data that I showed you before. So the birth certificate data on nearly 18 million babies from 29 states from 2000 to 2010. So what we're doing is using a population-level data set. So this isn't a sample. This is the entire population of babies to exploit the natural experiment created through increases in cigarette taxes and the enactment of smoke-free legislation across and within U.S. states over the past decade. So all of the 29 states here are in our data set. So you can see a really nice distribution about this geographically. So each mother is then linked to the specific cigarette tax at the month of their delivery, as well as whether there was smoke-free restaurant legislation at the time of birth. So you can see here the very large variation in cigarette taxes, even as of December 2010. And so the lightest color here is a tax of $1 or less. The middle color is $1 to $2, and the darkest color is $2 or more per pack. And just to show you the extremes, we have Missouri here that has a tax of 17 cents per pack, compared to Rhode Island, which had a tax of $3.46. So here I wanted to show you in our BC colors that as of December 2010, 19 of the 29 states had smoke-free restaurant legislation, which is shown here in the burgundy, and the gold are those states that had no smoke-free policies. So once we've linked each mother to their policy data, we then use a causal inference technique from economics called differences in differences models to test whether changes in tobacco control policies were associated with changes in maternal smoking during pregnancy. So now the best part. We're moving on to the results for the mothers. So what we found was that every $1 increase in cigarette tax was associated with a reduction in the prevalence of smoking among low-educated white and black mothers by approximately 2 percentage points. And on the birth certificate, they also asked moms the number of cigarettes they smoked. And what we found was that among these smokers, they consumed approximately 18 fewer cigarettes per month. Now, we found no effect of smoke-free legislation on smoking behaviors. It was only the taxes. So here are the results for the babies. Every $1 increase in cigarette taxes raised birth weight by approximately 5 grams and reduced adverse birth outcomes such as low birth weight, preterm birth, and small for gestational age among low-educated white and black moms. So when you put this into perspective, what does this actually mean? So according to our estimates, if Missouri, whose tax in 2014 was actually still 17 cents, if they raised their tax to that of Massachusetts, which is $3.51, the birth weight of infants born to Missouri mothers with less than a high school degree would increase on average by 18 grams for white infants and 13 grams for black infants. So remember, this is all in response just to a tax at the state level. So we also found no effect of smoke-free legislation on birth outcomes. It was just, again, the taxes. So what are the implications? So we found that cigarette taxes may be an effective population-level intervention to decrease racial, ethnic, and educational disparities in maternal smoking during pregnancy. And they may be also effective in improving birth outcomes related to smoking among the highest risk infants. So considering that US states increase cigarette taxes for reasons other than to improve birth outcomes, these findings, we believe, are welcome byproducts of state-level policies. And then, I wanted to end by talking about how my work fits into public health research here at BC, and then how I think we need to move the field forward. So first, you've heard it already, Boston College cares about social justice. We care about identifying vulnerable subgroups of the population and then applying public health approaches to help achieve health equity. For example, something I think we should be very worried about is that globally, adolescent girls are now smoking at rates similar to adolescent boys. And in some countries, they're smoking at higher rates than adolescent boys. Also, tobacco companies are now targeting countries with weak policies. And the downstream effects then could be very devastating. So just think about then the implications of that on pregnant women and consequently their babies. Second, I think we need to be more and more interdisciplinary. So my research combines methods from social epidemiology and economics to rigorously test the impact of policies on disparities in maternal and child health. I want my colleagues from epidemiology to think more like economists and to borrow their methods for policy evaluation. But I equally want my colleagues in economics to think more like social epidemiologists and care not just about the average effect, but specifically helping to identify those groups that may be at highest risk. Okay, and lastly, this big word we all love, big data. Okay, but I think honestly we need to invest in how we can harvest and harness the power of routinely collected data, like that we capture every day on the birth certificate. So an example of my other research that uses big data is something called the hospital discharge data, which captures every contact in the emergency department in a state, so every single contact to the ED. And what we've been able to do is link that data in Massachusetts, New Hampshire, and Vermont to the local and state smoke-free policies and cigarette taxes in order to formally test the impact of these policies on visits for childhood asthma, respiratory infections, and ear infections, which are direct consequences of secondhand smoke exposure. And lastly, to the students, and I'm thrilled to see some students from the public health class I've been teaching with Professor Sutherland, who's going to be speaking at today as well. And I think this is such an exciting time for public health here at BC. And what we're really trying to infuse all that this research day embodies into the new global public health sequence. So I hope to see more students in the classes up ahead. And just lastly, again, I'd like to thank my collaborators, particularly Kit Baum and Matt Gilman and Emily Oken, who are based at Harvard, as well as my funding from NICHD and the BC Research Incentive Grant. So thank you.
Hi, my name is Jim Keenan. I'm a Jesuit. I teach theological ethics. I've been here since 2002. My policy is basically how I teach a course on ethics that has an impact, I think, on quite a number of students. And I'd like to show why I think that happens. I entered the Jesuits in 1970, and my entry into the field of ethics is probably not like anybody else having an entry into their field of research. Mine came when my provincial arrived to Cambridge from New York one day, April 20th, 1981, to tell me that I was doing a doctorate. I said, I've been a Jesuit for 11 years, and I've been a community organizer and going to school, but a doctorate? He said, yes, we decided yesterday, and we thought you should be the first to know. And told me I had 24 hours to decide the field. I went back to my community, and you've heard a great deal about Jesuit discernment, but you should see how it works within our ranks. And I was told I had 24 hours to come up with a field, and I returned to my community, and they all said, you should go into ethics. I said, why? They said, you do well in it. And so I returned and said, okay, I'll go to ethics. I ended up going to the Gregorian, which was not a place that a lot of community organizers had gone to. This is the major Jesuit university, and I was there from 1982 to 1987. I went there for one main reason. I felt that by 1982 in the Catholic Church in the United States, that as a matter of fact, the only people who were invoking tradition, which has an enormous impact on leadership in the church, that the only people who were doing that work were really rather conservative people, and that anybody who had the slightest progressive instinct had abdicated any interest in the tradition. So I went to the Greg to study with two men, Joseph Fuchs and Klaus Demmer, and I worked on Thomas Aquinas among others, but I was trying to learn the tradition and to learn it as something I thought would be more humane, more serviceable, more accessible to people, and certainly much more socially just. At the same time, in 1982, of course, the outbreak of HIV is known throughout the world, but in Italy, and in Rome in particular, it remains fairly dormant in terms of interest. I finish up in 1987, my doctoral studies, and in 1987 I start teaching at Fordham. While I'm teaching at Fordham, I'm only there 2 months, and the American bishops come out with a statement called The Many Faces of AIDS. It's authored by Cardinal Bernardin in Chicago, and in this statement, he says that the Catholic Church could make accessible and support the use of condoms for not contraception, but rather as a prophylaxis for inhibiting the transmission of the virus. The next day, on November 15th, 1987, 6 cardinals repudiated the statement, Cardinal Law leading the charge. I therefore decided, well, I spent 5 years trying to learn the tradition, to say that the tradition is more humane, more rich, more robust, and more interested in social justice than many of the conservatives espouse. And so my first academic article was this. I wrote on condoms. It was really interesting to go from Thomas Aquinas to condoms. My first book was Aquinas. My first article was condoms. I've been writing on this topic now for, I'd say, since that came out in 1989, and came out as a response to what the bishops were doing. I've been writing on it precisely because most of the people who do talk about condoms, who are priests or bishops or cardinals, do it to impede the information about the effectiveness of condoms in inhibiting the transmission of the virus, and I take the opposite point of view, arguing from tradition why it is justifiable, and I do this worldwide. I speak in quite a number of different places. Because of that work, I became very interested in more and more bioethics, and I was subsequently invited by the Jesuit Institute. It was run at that time by Father Michael Buckley. He gave me a $10,000 check, and he said, I think that the American bishops have blood on their hands by impeding this information on condoms and on other prevention strategies. And so I've put together a team of a Jesuit who was an AIDS physician, John Fuller, Lisa Cahill, who was on the faculty here at Boston College, and Kevin Kelly from Liverpool. And the 4 of us together invited 35 ethicists from around the world to write about obstacles that were occurring in their part of the world that impeded them from being able to talk about HIV prevention strategies. These were really, really fascinating cases in which people were talking about whatever was the issue in their particular country. Linda Hogan, for instance, she's the provost at Trinity College Dublin. She wrote a piece about a woman, a nun, a religious woman, who was teaching in a very poor section of Dublin, and she was working with kids who were at high risk for HIV, and she was trying to give them real clear information, and how the Archdiocese had come down on her and on her community, and the pressure that she went through in trying to talk and work with these students. But we had 35 different essays, 35 different people from 27 different countries. The book was reviewed in more than 50 journals. No religious organization of any kind had ever done a work like this that was international in scope. And of the 34 contributors, I'd say about 28 had not yet written on the topic of HIV/AIDS. So by being invited into our project, they became galvanized in it. We had, for instance, a Jesuit from Egypt writing a piece about what it was like working for a Catholic agency in a predominantly Muslim country and trying to do information about HIV prevention. What were those obstacles? While we had another one, an Indian, writing about the difficulties he had in working with a predominantly Hindu government. So we had, in a variety of different ways, people addressing the issues that were distinctive to their particular culture. Because of that, I ended up deciding that I should teach HIV/AIDS and ethics. And this is a course that I've developed. I just finished my last lecture yesterday. We have 60 students in the class. I teach it once a year. It's an elective. It's in theological ethics. And I just thought I would show you some of the work that I do with the students to give you some sort of concrete understanding of it. What I try to do, I have two main expectations of the students. It's a discussion-run class of 60, which is it's fairly entertaining. But I have 2 oral exams. I want the students to be able to speak about HIV/AIDS. Today, 39 million people are dead from HIV/AIDS. 39 million people are dead. 34 million are living with HIV. And 3.3 million are children living with HIV. 1.7 million died in 2011. 1.5 million died last year in 2013. These are really enormous figures, and I'm the only one who's been teaching a course here at this university on HIV, the largest pandemic in our history, in our lifetime. And I do this effectively alone and have been doing it for these years. And I thought that this is an illustration of policy in what is the function of the faculty to reflect on contemporary issues that are facing us in the realm of public health. So this is a course that we teach. They use the book Catholic Ethicists on HIV/AIDS. There's another book there that we use. Donald Messer. He's an evangelical ethicist. So we have a Catholic and a Protestant basic way of looking at this course. In it, I start with the UN/AIDS report each year. This is a groundbreaking issue for the students. This gives them all the factoids they want. It's about a 200-page piece of writing. And then I start right away with theological issues. This is one of those articles that all of us always love in ethics. John Michael McDermott's is AIDS, God's Punishment. This is by a Jesuit, and he says yes. You've heard people believing this, but you've never met them, and they never put their positions down in writing. So I start the course with this essay. It's very effective. Frank Sanders is a German who writes about this same topic, different perspective, to refute what he says. Then I look at what the American bishops have done, and then we look at a case here. This is from Scotland, where they set up a whole, Edinburgh is a big needle exchange program that they were trying to set up that was again thwarted by the archdiocese there. Then we start looking at other religious claims. Laurenti Magesa is probably the leading African moral theologian, and his work is to basically say that there was no work with tribal religious leaders, giving them information about what they needed to know about HIV prevention. So tribal religious leaders may have been involved in practice like bloodletting, but nobody engaged them about why that was problematic. Mark Miller did it with First Nation people in Canada. Diana Hayes is a black womanist down in Georgetown. She wrote about the population, the African-American population and HIV and how they've been affected. And then we looked at homosexuality in the church, stigmatization, and theology. We had extensive work on women. Women is really the major the question of gender equity keeps coming up throughout the course. We look at teenagers, we look at transmission issues, we look at the question of instability, solidarity, and structural violence. This is where I begin to teach them language games so that they can understand what type of rhetoric they should be using in trying to advance issues about HIV/AIDS. Then we do stuff on prevention. You can see some of the work that I've done with John Fuller on condoms, but then we subsequently did work on intravenous needle exchange programs, and then what is the effect of teaching? Then I teach them the arguments that we have on HIV so that we can understand that there are issues of social justice, the really groundbreaking work by Jonathan Mann on human rights language, how that's been appropriated by others, how in the Catholic tradition we use the language of social justice. I have Maria Simperman and Lisa Sol-Cahill there and myself. And then what are the developments that have happened since then? And because of teaching this course, I do write quite a bit on HIV. It's probably about 10% of my writing, but I do keep asking new questions like, how has the field of public health changed because of HIV? Or how has discourse on HIV led us to understand the need for universal health care? And finally, we do cases of research. This is a very famous case of Marsha Angel on the transmission of the virus from mother to child. And then we do treatment and patenting issues, limited resources, and we conclude with signs of hope. Because of this, with 60 students a year, I have the most activistic students at BC in my class. Whenever there's anything happening on campus, they've already talked about it in my class. So the editor of the Heights will be there, the leaders of Students for Sexual Health are there, the leaders of the fossil fuel debate, they're there. Anybody who's a rebel rouser comes to this course, and others, because there's not that many rebel rousers at this university. But this gives you an idea of some of the doctorates. But before that, before concluding with that, I've had 4 students, undergraduates, who've worked with me on their honors thesis project. One is Brianna Norton, Michael's daughter, worked on women in Africa and how they're affected by HIV/AIDS. Adi Ashok, who won a Truman and a Marshall, and worked in the AIDS office at the White House as a Truman Scholar. And he's now at Harvard Medical Center. Kat Wakeham, who worked on the transmission from mother to child, the experiments that were going on in Nairobi. And finally, Dave Cody, who was graduated last year with the Finnegan and won it for his honors thesis, which was about working with children in Nairobi who were AIDS orphans. But this is the list of doctorates that I've been involved in. A Nigerian who worked on basically considerations of gender and justice in Nigeria. Maria Simperman, an American who worked on fundamental ethics. Pat Mumbe, who became the director of the African Jesuit AIDS Network, who publishes quite a bit. He recently did a new book called AIDS 30 Years Down the Line, Faith-Based Reflections in the Epidemic on Africa. Vincent Leclerc, a physician who worked with me, did a PhD in ethics of vulnerability. He wanted to write about doctors and nurses, medical workers who are affected by HIV and why vulnerability is so important. Another physician, Bertrand Boucher, who wrote about Where Were You When I Was Sick. Gillian Patterson, who did not work with me but as a colleague, worked in England and did a doctorate on stigma and HIV/AIDS. A Peruvian Jesuit who worked with me doing the uses of the language of human rights and couples it with the language of social justice. Azotope Jacquinot, probably the most fascinating person in that list. He's another Jesuit. He's a Cameroonian who worked on the principle of equity in healthcare and complements that perspective with the option for the poor as a means for guaranteeing equity. After he finished his PhD here, he did an MPH at Johns Hopkins, and he's now at the Gregorian, where I studied Thomas. He's now teaching AIDS. And finally, Mary Jo Iozio, who is on our faculty. She's at the School of Theology and Ministry. She did a sequel to the book that I had done on Catholic ethicists on HIV/AIDS prevention. This was a collection of essays by 45 women around the world addressing the issue of AIDS. I think that by this work, of the work in the classroom, I'm trying to show you how it actually impacts our students and the field. Thank you.
I'm sure you all agree that this was a wonderful example of the breadth of the work that's happening at BC. And I'd like to ask you now if you have questions that you'd like to share with our panelists. I think we have about 15 minutes for questions. And again, there are people who have mics that are going around. So, questions for any one of our panel. There's a person up here and there's a person over here.
Hi, thank you. My name is Joyce Edmonds, and I'm from the School of Nursing. And I was interested in your NIOSH database in thinking about nurses on different units, and if you were able to control or discriminate among different units in terms of working in an ICU versus an emergency room or a medical surgical floor.
Yeah, so we are able to take account of units in all of these analyses, and actually I did these as multi-level models. So I was able to see whether someone in a unit who had a very high level of abuse was more likely to experience an injury than someone in a unit with a low level of average abuse, even if they were not abused themselves. And actually found that that was the case, that it's sort of this culture. And we also looked at different environments within the hospital, so ICU, OR, ER. And I think we found that it was orthopedics, OR, and ER, and maybe ICU that had the highest or the strongest associations, which sort of makes sense because they're so fast-paced, a lot of pressure, sort of life or death situations, and a lot of power dynamics going on.
I could just add to that. Most of the research that comes out of this database thus far is in fact unit-based, and that's because of the interest in seeing the implementation of policies at a unit level, which I think is sort of interesting from an organizational perspective.
Thank you.
I was curious also about your work. There's been a lot in the news recently about the nurse in England that was confronted by the royal family during the princess's pregnancy. And I was curious if you had any insight about what kind of preventive policy there is in cases like that where, you know, the whole world is kind of watching some kind of harassment lead to a really serious mental health defect.
So I actually hadn't been following that story. But I think that the really perplexing thing about a lot of this is that it's really easy to figure out what the problem is, and it's really difficult to find a solution. And trying to think of what the intervention would actually be to reduce bullying or harassment or abuse or disruptive power dynamics in the hospital setting, I think that that's a much harder task than sort of saying, look, you know, these things are bullying is associated with all these different health outcomes. But we're working on it.
Yeah, and again, you know, I think what's interesting about it is looking at it on a unit level with the idea that perhaps some intervention by the manager or by the hospital may be appropriate rather than just seeing it as sort of an individual problem.
And seeing what's different about the units that don't have this problem, and seeing what's different about those unit cultures that you could then potentially bring to another unit.
We have a question over here.
I just wanted to follow up. Thank you very much for all your presentations about Summer's work. It seems that there's a lot that different states could learn from each other. You gave the example of Rhode Island and Missouri with very different tax rates on cigarettes. And maybe if we went to the global level, there are things that countries could learn from each other. You know, what are the barriers? Why does that kind of learning, knowledge sharing not take place?
Well, I think sometimes we think of the U.S. with all the states as they could be all different countries. Part of it is tradition, so a lot of the southern states are still very strongly rooted in the tobacco growing culture, so you have a lot of lobbying groups that are now trying to push back on taxes, and that's a real barrier to getting some of these states to increase their taxes. So we do see some geographic kind of bunching about that, although our model is able to take all of that into account. And I think globally, you know, it just has huge implications because the tobacco companies are now trying to move into these new markets because they've really had this pushback from here in the U.S. And I would welcome the opportunity to be able to look at some of these global issues. I think sometimes data is a very hard problem because we have such rich, complete data here and not other places. So I think there's a lot of different avenues that we need to work on to try to help generate the knowledge that can then inform the policy.
Please.
So, I lived in the South for 10 years. I noticed that Georgia, Alabama, and Mississippi are all on the wrong side of the ledger, but curiously, North Carolina and Louisiana were on the right side. Correct side, I should say. How do you explain that? What happened in those two states?
I don't actually know the history of some of the policy development, but there has been a move in most of the states to kind of, because of the evidence, to push the taxes up slightly more. What's also been very helpful is that federally, people have recognized this as a big way to decrease smoking levels. So, for example, a few years ago, we saw a $1 increase in cigarette taxes. So even in those states then that had very few or very low policies, people are now being hammered by a much higher tax, and we've seen decreases in smoking from that.
Other questions?
I have a question for Father Keenan. It was during the keynote talk, the speaker pointed out the delay that the federal government, the delay in funding for the follow-up to treatment for 9/11, and it reminded me early on in the AIDS epidemic, a similar delay in federal funding for AIDS research. And I wonder if that's something that would be considered an ethical issue on the part of governments and something you might discuss in your class.
Well, what I try to do in the course is I try to take up a variety of different, each year I put in different cases that we should look at. This year, we did something with films to just talk about how the films, like How I Survived the Plague or A Normal Heart, these different films that have come out to try to say what were the major contentious issues to look at during the first 10 years in which there was really not much cooperation from the federal government, and there were an enormous number of problems with the FDA in trying to approve or actually to sidestep some of the procedures that they had developed. So we keep coming back to questions like that. I just showed them the Dallas Buyers Club 2 days ago in class, and it actually prompted quite a lengthy discussion about what the government was like in trying to promote AZT without knowing how toxic it was.
I had a question for Dr. Hawkins. I was wondering, there's obviously the variance in cigarette taxes, but have you done any research on how much of that tax actually goes towards public health prevention versus kind of balance the general government budget?
I haven't done specific research on that, but there was a master settlement, and much of that the money was supposed to go to public health prevention and efforts, but unfortunately it has not. It has actually gone to plug different holes in that. So as of now, I don't know specifically by state, but my impression is that the majority of funds, unfortunately, are going to plug the holes in different budgets, and it isn't going towards public health efforts. I think that that would be a great way to build an earmark it, but as of now, it doesn't seem to be the case.
So we'd like to, do you have one more question, one final question?
A quick one for Father Keenan. With the new Pope in place, have you seen any change at the highest level in the
Well,
churches?
you know, it's so funny, one of the reasons why I got involved in condoms so early was simply that this is an issue about men's responsibility in a time of the plague, and how so many men have talked other men out of using condoms, including those who have high rank in the church. And when Pope Benedict was elected Pope, I was contacted by Reuters if I had any projections on that. And what was funny was that somebody from the Opus Dei had published an article in the Tablet saying that it was okay for discordant couples to use condoms. This is the same position that I had done. So I thought, as a Jesuit, I should acknowledge that Opus Dei and the Jesuits have often thought alike, and have thought alike, especially in the case of condom prevention, and that since the two of us agreed, everybody else should agree. And I later found out that this article was done under the promotion of the Director of Public Relations for all of Opus Dei out of England, and he came here to do a documentary about Opus Dei, met with me at length to tell me that when that article was published, it was submitted to then Cardinal Ratzinger, who read the article by this fellow from Opus Dei, and he said, you know, this is the same position as I have. I found that really remarkable because I've been writing on this, and though I get in trouble with the Vatican on a number of different issues, I never got into trouble on my position on condoms. So I knew that there were sympathetic people in there. So when Reuters asked me, did I expect to see anything new from Pope Benedict, I said, yes, I expect to see that he'll say something positive on condoms. I got a note from Opus Dei immediately saying, I wonder who told you that. And it went worldwide, but the Pope did actually make these comments about when it would be licit for somebody to use a condom. So I'm sure that Pope Francis has an even more open mind on this question than Pope Benedict.
Thank you so much for your excellent questions, and the next panel will be immediately coming up.